Yep. So, hi everyone. Thank you so much for joining our seminar today with Dr. Rohan Krishnan on the topic of assessments for dental decay related to injury and medication. So, during the presentation, the attendees will be muted to avoid any random noises that might distract the presenter. If you have any questions, please pop them in the chat box below, and we will attend to them at the end during the Q&A session. So today we have Dr. Rohan Krishnan. He has vast and varied experience and training in the multidisciplinary management of jaw joint dysfunction, and he is well regarded in the field of TMD, including consideration of mental illness, sleep, and pain, as well as facial injury and impairment. So over to you, Dr. Krishnan.
Thanks, Sophia, for that. And thanks to those of you that are joining, probably most likely over your lunch break, and look forward to hearing your questions after we finish. And for those that are watching this after it's already finished up, more than happy for you to reach out through MAG to contact me if you need queries, any questions answered, or advice on any matter. So the topic of today is the assessments for dental decay, the clinical term being caries, which is dental caries or dental decay related to injury or medication. And we'll go through that today. So the types of dental injuries or injuries that we can have that can lead to dental caries or decay include traumatic injuries, medical conditions. So traumatic injuries, meaning any sort of blunt force trauma or penetrating trauma, burns or falls, which we see that have a direct impact on the dentition that then lead to a vulnerable tooth that then subsequently becomes decayed. Medical conditions such as diabetes, health conditions that affect dexterity or that affect ability to care for or look after teeth can also be conditions that we consider. And medication-induced injuries as well as medically induced injuries. The difference being with that, medication-induced meaning things that affect the oral environment and saliva, and medically induced injuries, I think probably in legal terminology would be classed as medical negligence in many instances, and they can also lead to dental decay if there has been an inadvertent knocking of a tooth, most commonly during anesthetic procedures, and that's why there's a declaration on a lot of the forms operatively for patients that are about to have anesthetics or go under a general anesthetic procedure. So everything from medical negligence through to traumatic injuries are covered, and they all render teeth or the dentition vulnerable to a decay process down the track. And we'll go through why and how we assess those types of injuries and the factors that need to be considered when assessing these injuries. So really, we're looking at medical factors and injury-related factors, because the medical factors are the intrinsic factors related to that person: saliva, their immune system, their diet, and their oral hygiene. These are the factors that cause tooth decay or tooth breakdown from a bacteriological perspective. And then the factors that actually impact those medical factors, or the ability of those medical factors to actually prevent that disease progression, are all the injury-related factors. So that first wheel that you see is impacted upon by that second wheel, which is the injury. And these are, when it comes to dental decay, because it's a secondary process of bacteriological disease that then leads to breakdown of teeth, there needs to be a breach or a break in the enamel, a tooth crack, a pulpal involvement, that is involvement of the nerve inside the tooth that leads to nerve death and infection, or a jaw injury that then predisposes the patient to have issues down the track. We touched on injuries relating to medical conditions, injuries resulting in medical conditions, and a common example of that is an amputated arm or a carpal tunnel or something like that, that then leads to an inability to be able to care for the teeth as well as the person normally would be able to. And this is not to say that all of these factors are necessarily compensable. The importance of the assessment is to determine whether these injuries are in fact compensable or not, and whether more likely or not this would have happened without the injury, or because the injury has occurred, now this process is taking place. So I think that's the thing that I'd like you to have in the back of your mind when we're going through some of these cases and some of the causation mechanisms. So medical histories, the factors that affect the balance between bacteria and the immune system, and the immune system's capacity to deal with that bacterial challenge. That's the tug of war that we see. We've got the bacteria and then the immune system. And any factor that affects that balance due to an injury could be considered to be compensable, and it's a case-by-case discussion. So they're medical conditions which are intrinsic, or dietary, which would be considered extrinsic. We'd like to consider the oral environment. So what is the level of acidity or buffering capacity of the saliva, the dexterity of the person, their motivation and their cognitions, and their ability to actually care for themselves and their dentition to prevent bacteriological breakdown, and of course diet. So and pharmacological impact. So a lot of conditions have, for example, chemotherapy, antidepressants, pain medications can all cause changes to the quality and quantity of saliva that's produced. And saliva is the biggest single protective element or factor in ensuring that teeth don't go down the path of caries or breakdown into a decay state. So when we have some people that come in who've either lost salivary glands, or they've had radiation therapy, or they've had, in fact, chemotherapy to those salivary glands, or they've had medication that has impacted those salivary glands, like I've mentioned with antidepressants or pain medication, and there's various medications that can affect saliva. Then we look at to what level has this affected the dentition, and we'll go through some of the factors that we consider or the clues that we look at to determine whether it has been affected to the point where there's a compensable injury at hand. And we always consider the pre-injury condition, because there are some people that come in with a high caries risk or dental decay risk, or pre-existing disease that has rendered their dentition or their teeth incapacitated pre-injury, and they're really important to consider as well. So what is an independent dental exam with regards to an IME situation? So look, it is really difficult to do via telehealth. We tried during COVID at times to even treat patients, and it's I would say it's less than suboptimal. It's almost a void method of doing examination and treatment, purely because some of the changes that we're looking at on teeth and gums and in the soft tissues, 1 millimeter, 2 millimeters or less. They need 3.5 times magnification loops or more, and a high-powered light to be able to visualize these changes. And so doing a telehealth consult is really tricky to accurately make a diagnosis and then provide an opinion. So what it does require, though, is a detailed history and examination. Questionnaires. We use a very varied list of questionnaires depending on what we're looking at, and we standardize that across the base, from medical histories and pain histories through to looking at jaw function, psychological questionnaires, pain drawings. We'll go through a few of those today in terms of what we do, saliva testing, an extraoral exam and an intraoral exam, and investigations that include pulp and sensibility testing, radiographs, and also jaw function and occlusion. So there's a whole range of stuff that we look at, and we need to go through systematically those processes in order for us to be able to make an accurate diagnosis and provide an opinion. We also take a lot of cues from things like body weight. So body weight is directly related to, or is a risk factor for things like obstructive sleep apnea, which could be the reason for a sleep disturbance rather than mental illness, for example. Sometimes the patient or the person might claim that they've got an issue with sleep that's been caused by a distressing incident, but it may be actually that their obstructive sleep apnea as a result of their central obesity is the most critical factor for why they're getting those sleep disturbances. Alternatively, or in another case, we might have a patient that or person that comes in with a diet history that says that they have a very healthy diet, yet they somehow have a BMI of 40. And when we observe them in the chair, we're able to see that what they're saying that they're eating doesn't correspond with what necessarily how they present. So there are these cues that we can take from people. They might say that they can't brush, but then they can quite easily do a number of other activities when they present into the clinic, like rinsing with a cup of water or scratching their head or their face, and all of a sudden then we realize that maybe they should be able to use an electric toothbrush, but they say they can't. Or they may in fact not be aware of a dexterity issue that they do have that's actually leading them to be incapable of managing their dental state. Could go the other way as well. Their ability to speak, enunciate, and form logical conclusions and discussions gives us a little bit of an inkling into their return to work capacity, especially if they're motivated, highly passionate, and able to construct good logical arguments, and their previous role was a non-physical role. Then that gives us an ability to make to have an inkling into what their return to work might look like, and their jaw mobility as well. So sometimes we'll have people come in saying that they've got functional jaw issues when really they've got full mobility and range, and their history doesn't correspond with the way that they present for examination. We could go through the whole jaw depression and anxiety cascade and bruxism another time. I don't want to go into that today. That is a pet topic of mine, and I lecture at 2 universities and work in multidisciplinary teams to manage jaw conditions. So that's maybe a lecture for another time, but pre-existing records and clinical records really are quite important for us to be able to help us be able to make an accurate diagnosis and also determine causation. So some of the questions that we ask, we might frame a question: do you eat healthy food? And if so, what do you regularly eat versus how well can you chew? Because what somebody eats gives us an idea of what they can chew. Whereas if we ask them what they can chew, they might downplay or they might augment their response based on what they want to gain out of the session. So it's really important that we think about the questions that we ask. How long have you smoked cigarettes for? Gives the person an idea that maybe we do already know that they smoke from either previous histories or from their examination, rather than do you smoke cigarettes? And of course, some of these questions are a little bit cheeky, but I think these questions are very valid in terms of being able to garner an honest response. And sometimes we may struggle with openness and honesty, even though it's something that we expect from the people that present to us. And then, do you snack a lot during the day versus describe your daily food intake? So do you snack a lot during the day is a how are you question. People will probably just say, no, not really, rather than just like they would say when you ask them, how are you? And they just say good. Whereas describe your daily food intake gives them an opportunity to actually elaborate, a bit more of an open question. So saliva and salivary glands. I see a lot of dental reports that I get, and very rarely do I see a salivary gland test on them. We do them routinely. The group of dentists and doctors that I do IME reports with, we do saliva gland examinations and testing, and use the pH indicators to determine the pH or acidity of the oral environment is a great indicator, along with the quantity and quality of saliva that's produced, about whether the salivary glands are functioning properly or not. So as we mentioned before, with patients who've had chemotherapy or in fact radiotherapy, especially to the head and neck, or they've had a numerous number of other medications such as antidepressants or pain medications, there can be an effect to the saliva or the salivary glands. And if there is an effect that manifests as a acidic pH on rest, then we take their stimulated pH to see if there is a better pH result with their stimulated test, because they may have I mean, we try and determine that they have or haven't had acidic drinks or food before they've come in, but it's not always the case. And so sometimes a stimulated salivary gland test where they chew on a bit of wax and then spit into a cup and we test their saliva is a really good indicator of their saliva function. So for people that say that they've got medication-induced destruction of teeth and they present with very healthy saliva, that's a real contradictory investigative finding for us to then determine that maybe their saliva is actually okay, and that their dental decay or breakdown is from other causes, not from a medication-induced cause or a cause that's related to a claim. So that's really fascinating for us to look at, and it gives us an indication of what their future sustainability of their dentition is as well. So I talked about pain history and questionnaires. I won't go through this too much today, but it does give us an idea of correlating our exam with what they feel and where their pain comes from. We do a PHQ-4 questionnaire, sometimes a PHQ-9 questionnaire, which psychologists and psychiatrists use. Pain specialists use as well to determine especially with TMJ, we have Axis 1 and Axis 2 factors. The Axis 1 factors being the biomedical. And since 2014, a paper by Schiffman et al., if you've got some spare time and want to do some reading, it was a landmark paper in pain in terms of looking at the psychosocial or emotional affective factors that need to be considered for a person who is experiencing chronic pain, and what level is their psychosocial state impacting on their pain experience. So this is a great questionnaire for us to look at whether this is a big factor or not. So is treatment reasonably necessary? This is straight from eye care. And we actually look at a lot of these factors in terms of helping us determine whether, when we're reviewing a request for treatment and a quote, whether it's reasonably necessary or not. So injury related. So is the actual treatment related to the workplace injury? So that's a pretty straightforward one in terms of determining whether there's a link or not. And if it falls down there, then we don't sort of really need to go much further. But it is important for us to sort of really flesh that out. And sometimes it can be complex to determine. But once we've done our examination, it usually is pretty, pretty plain and simple to see whether there is actually a causal link or not. The appropriateness of the particular treatment. This one sometimes is a little bit variable because a dentist may treatment plan a whole range of things that may be a want rather than a need, or may be not reasonably necessary, but actually, best practice for a situation where we want to achieve, a rehabilitation that is consistent with well beyond just normal functioning. So an example of that, and we'll go through a little bit later. Actually, I might skip forward to it, is this one here, where you've got a chipped tooth or two chipped teeth from a direct trauma. Now, is this reasonably necessary to fix? Well, yes, we're returning that person to their pre-injury state. So I guess you could say it is reasonably necessary if you're able to find the factors that prove conclusively that the workplace injury was actually the cause of this, these two teeth being chipped. Now, that particular patient I saw to not for a claim, but for treatment. And you can see with the treatment that's been done that it's just a composite resin restoration, which is a very simple filling that restores function and aesthetics to that to those two front teeth. Now, the cost of something like that might be $250 per tooth. And I've seen routinely dentists put forward treatment plans where for teeth like that, veneers or crowns have been quoted, which is in the order of thousands. Sometimes, for two teeth like that might be $4,000 or $5,000 worth of treatment. Now, is that reasonably necessary? If we go down to our eye care list there, it's probably not right at the bottom. It's probably not accepted practice for someone who's got two small chips like that to have a crown or a veneer. And then the question poses, well, if you're going to do crowns and veneers to those two teeth, then quite often we see the mirror teeth, that is the teeth that are next door to those teeth, also then be treatment planned for crowns or veneers, because we want to a matched or balanced aesthetic uplift to the two teeth that have been damaged. Now, in my mind, that's not reasonably necessary and it's not compensable, very clearly. Even though it's an accepted option for treatment planning, and in normal private practice situations, you're well within your right to, as a patient with informed consent, to acquiesce to a treatment plan where you're having a cosmetic uplift to all of your teeth. However, that's not necessarily, it's definitely not returning the patient to their pre-injury state. In fact, you're completely altering or augmenting their original state to a new enhanced state. Some would argue enhanced state. I would argue that it's probably just over treatment. And that's an example of whether the appropriateness of the particular treatment checks out or not. Now, the cost of the treatment, is the treatment and care cost effective? Are there ways and means of doing the treatment with more efficiently, with less burden to the patient, and with a lower cost? And so I think these things are all important to put in the report, and we routinely put those into the report for various claims. This is an example, again, is this reasonably necessary? So this is another patient of mine who came in with a fractured tooth and cusps. And that tooth that you can see right there in the middle on the top right quadrant is the fractured tooth. Now, that's the same tooth that you see on the top left from a side view angle. And you can see from the side view angle that the person is not actually even biting when they're in full bite on that tooth. So it's a non-functional tooth that's broken down. Now, if that presented from a workers' comp claim because the person had a punch to the face and a direct trauma and there was a fracture to that tooth, well, we'd say yes, okay, maybe there is a case there for this to be repaired and the claim could stand. However, we quite often will see that the treatment plan will be, again, for a post-core crown or crown lengthening and a crown, or something that is in the order of thousands of dollars for an ideal treatment that is probably not reasonably necessary, because the tooth doesn't need that level of functional integrity and strength. All it needed was a simple filling. And you can see there with the filling that we've done that it will suffice. And it's, again, a couple of $100 solution rather than a few $1,000 solution. So these are things to consider. And again, we might look at the claim and the person might present with a broken nose and front teeth damage, and therefore it may be unlikely that this particular tooth, which is so far back, has got any link to the incident, to the work-related incident. It may be that this tooth was going to undergo a fracture or have a filling and part of the tooth fracture anyway, irrespective of the work injury or not. And so, pre-existing x-rays and pre-existing fillings, if that's a 40-year-old filling that was in there before and you've had a bit of a tooth fracture and a filling fracture, I would argue that was going to happen anyway. So yes, the work incident, we can't confirm or deny that it was definitely a cause or not, but it was going to happen anyway at some stage, and therefore that will be a factor that we consider when we're writing the report. So the effectiveness. So is the treatment actually effective? So a lot of the time, I get this a lot with TMJ related care. We'll get things like occlusal splints, not as an adjunct, but as a sole treatment. So a night guard or a anti-grinding guard to stop teeth from breaking down. That will be a proposed solution on its own. And there's no evidence to suggest that occlusal splints on their own actually work. They work as an adjunct to help symptoms in conjunction with physiotherapy maybe, or psychological care. Sure, they can be an aid. But to use a occlusal splint all by itself, or to use a bimaxillary, like an anti-snoring device to stop snoring and prevent breakdown without a sleep study, these things aren't potentially going to be as effective as they could be, and therefore we consider that in what we write for our report. And what other alternatives are there? Are there other treatments? Are there ones likely to give better results? A classic example for decay practices, and I'll show you one here. We'll skip to it. Is this is an example of a decay pattern that happens with people who've got significant salivary issues, because it tends to attack the point of lowest entry into, or easiest entry into the tooth, which is the root areas. The root areas have are much more vulnerable. They don't have enamel on them, and so if saliva is not doing its protective function, we tend to get decay patterns that look like this. And in those instances, if we go back to the alternatives, we've got to look at, sometimes we'll be given an example of a patient that presents with that type of decay pattern where the teeth are having to be removed and implants placed. And that might not be in the patient's best interest or the person's best interest, because they may be able to have good restorative care, as you can see there, where some of those fillings have been done, that allow for the person to get to MMI without having extensive surgical work done. And it preserves the longevity of their teeth. It promotes good oral hygiene practices and is in their best interest. So these are other factors that we consider. And we talked about acceptable practice. We've gone through those. So preclinical records. Is the patient a regular dental attender? That's a really good clue for us, because we have a lot of people that come in who may not be regular dental attenders, and therefore we can look at their current state and make some valued judgments around whether their lack of dental care has led them to the breakdown of or decay that we see in the mouth, or are they a regular dental attender? And if they are, what has been done in the past that has allowed for this to occur or not allowed for it to occur? And do we have records of that? Because if they are a regular dental attender, we should have access to their previous records. So how have things changed post-injury? That's another question we always ask, because post-injury, have they not been sleeping? Have they not been working? Have they not been brushing? Have they not been looking after themselves as well as they'd normally be? And then is that enough for us to say that more likely than not they would have had this breakdown without the injury? Or is it a case that with the injury that this dental breakdown has occurred? And what are the factors that we consider post-injury that have led to us to have those conclusions or come to those conclusions? What is the pattern of decay and breakdown? That's another question that I think is a very, very dental specific question that only a dentist would be able to resolve. And is it consistent with the injury type and location? And has there been treatment done or not that has contributed to decay or breakdown? And quite often there has been extensive treatment done, and we'll go through that again when we look at some further slides down the track of where there has been treatment that's been done in the past that has now led them to have a decay state now selectively on the teeth that have had treatment. And then we can form a view of whether or not the decay is actually related to the injury, or is it something that was going to happen anyway because of a pre-existing treatment that's been done, either properly or improperly. So this is an example of pre-existing disease. So this person, again, presented to me with a root canal that had started on the upper right. You can see on the x-ray there, on that first molar, in the top left, you can see a white wedge, sort of a white triangular opacity or coloration on that tooth, and that indicates that a root canal has been started. On the bottom left of the patient, or the bottom right of your screen, you can see that there's the first molar tooth has also had root canal initiated, and actually root canal has been completed, and that's why in the roots there's that highlighted white striation that indicates a root canal has been finished. Now, if a person like this comes to me without crowns being done on those root canals and they've got recurrent decay on those teeth, it's very difficult to attribute that to a workplace injury because treatment hasn't been completed. And so similarly with people who are grinding and clenching, those two teeth are the first two teeth that would usually break. And they would break because they're already compromised or incapacitated. So these are cues that we can get from a pre-existing radiograph. And in fact, this person came back with a fractured cusp on a tooth that had a root canal initiated. And ordinarily, there'd be an opportunity to say there's a medication-induced injury here or a workplace injury here. But in this particular case, none of those claims could stand up because the patient has actually, or person has actually had a pre-existing root canal that hasn't been completed, and therefore it hasn't been protected with a crown restoration, which would ensure long-term sustainability of both those teeth. So we talked about dental decay factors, and the biggest factor that I use with my methodology is an acronym called SEP, which I've invented, but it's just to help people to make sure that they don't miss the things that we should be considering, so that the experts, when they're looking at their points of injury, they can look at the site of decay, the extent of the decay, the pattern of decay, and the pre-existing decay history. So we spoke about the pre-existing decay history and how important that is. This particular person, you can see they've had an extensive pre-existing decay history. So factors like their diet, oral hygiene, and saliva have already been factors that have been problematic. So if they presented with new decay areas as a result of medication induced decay, or as a result of trauma or another factor, we would probably be looking at that and saying, well, there's an extensive decay pattern that's consistent with multiple factors that lead this person towards having decay as part of their disease conditions that they're chronically being managed for. Furthermore, you can actually see some mottling on the front teeth, and there's evidence of previous decay and current decay on the front teeth. And front teeth decay usually is consistent with an extrinsic source, like a soft drink or acidic drink that's being funneled through those front teeth routinely as the person partakes in those type of habits or activities on a daily basis, and that's pretty important. The other thing sometimes we do see is if we have a parotid gland or a submandibular gland that's been removed due to an injury, or due to or there's a medication-induced salivary gland problem, we see at the openings of the salivary glands, that is, at the opening of the parotid gland on both sides is up near the first molar, upper right and upper left first molars, and the submandibular gland and sublingual glands empty out just in front of the front lower incisors. So if we see decay patterns that have that have sort of in and around the area of salivary gland openings, we know that there's a salivary gland factor. And if the salivary gland factor is related to a compensable injury, then we know that there's a compensable dental decay or breakdown that goes with the original injury. So there are ways and means that we can work out through looking at the pattern of decay and the site of decay, what type of decay is existing, and how that decay has potentially become a problem. The extent of decay is also important. So is this decay something that is that has been going on for quite some time and has slowly made its way towards the pulp, or is it something that's occurred quickly after the work injury? So what is the extent of that decay, and what is the site of the decay? What is the pattern of the decay? SEPP, SEP is the acronym: site, extent, pattern, and pre-existing decay history. So they're all really important factors, and each case is a case-by-case situation that we look at, looking at the patient's medical history, their social history. What are their habits? Are they a smoker? Are they a betel nut chewer? Are they a routine, sugary drinking, snacker that is prone to carious disease or dental decay and breakdown? Or do they have none of those risk factors at all? And all of this stuff has happened immediately after or following a particular injury. And those are the things that we look for when we're forming our opinion and determining causation. So we have spoken about this, and the big question is it reasonably necessary or not, and why? We always give a rationale for why, and we try to do that in layman's terms, although sometimes that is difficult to do, because you can see the complexity that's involved in forming a diagnosis. And so therefore what we do use is pictures and radiographs, because they tell a story. A picture like this tells a story of rampant extensive decay, and if there are pre-existing photos or radiographs or a history of no decay before this, and immediately after a workplace injury we see decay like this, and there's a double confirmation with their salivary gland testing, then we can make a pretty good determination that there is a compensable disease entity that's occurring. And sometimes it might not be all of the teeth, but some of the teeth might be compensable and others may not. So there is a nuance with regards to how we look at these injuries. It's not necessarily a broad brush setup. We do look at every tooth specifically, and we consider the factors at play and determine whether the treatment plan that's been provided provides us an opportunity to, whether the treatment plan has been provided is, first of all, acceptable practice, and second of all, is it appropriate for what's been provided? Is it effective, and does it provide a path forward that actually helps rehabilitate the patient, or the person? So these are the factors that we consider. So finally, periodontal disease. So dental decay and gum disease or periodontal disease are the two biggest disease entities that we see, other than obviously pain as a major subgroup in the clinic. And gum disease or periodontal disease is essentially a breakdown of the supporting structures around the tooth. So the gum and bone and the periodontal ligament, or the ligament that holds the tooth in, are the structures that break down in periodontal disease. And periodontal disease or gum disease is a disease that is hereditary or genetic, but also influenced by factors like smoking and diabetes and poor oral health care. So people who have a genetic predisposition to gum disease or periodontal disease that don't smoke and that don't have diabetes or a high blood sugar level, and who look after their teeth well, won't get periodontal disease, even if they have a genetic predisposition to get it. However, if they don't look after their teeth well, and the factors of those immune considerations that we looked at before, the medical factors, if they are outweighing the bacterial, if they're being outweighed, or the protective factors are being outweighed by the bacteriological factors, then we get disease progression. Now, why is this disease entity so important in terms of determining causation for decay, dental decay or breakdown? Well, sometimes we might have early tooth loss because, as you can see with some of these x-rays, the bone levels of the teeth drop down so significantly that the tooth becomes loose, and the tooth actually is rendered infected, or actually becomes loose and falls out or is removed because of a gum disease factor that is unrelated to the claim, which the claim in this case or circumstance or context being dental decay and breakdown. So it is another overlaying factor that we consider. Does the person that do they present with gum disease? Is there an already questionable dentition? And therefore, if there's an already questionable dentition, is complex restorative work reasonable and necessary? Probably not. Reasonably necessary? Probably not. It is more likely that somebody like this is managed very conservatively, and when they do sustain tooth loss, other options like dentures might be a consideration rather than necessarily looking at implants as the first option. And quite often implants will be provided as the first option because it's what the person wants and what the dentist who's providing the treatment plan wants, because it's fast and effective and provides immediate betterment to the person's functional condition. However, it may not be in their long-term best interests. It's probably the most costly treatment planning option, and probably contraindicated in people who have gum disease, because the implant itself, the titanium implant, may fail to osseointegrate with the bone if they've got infection or disease. So that probably needs to be treated first before looking at those types of treatment options. So gum disease is a big factor. Is the dental decay caused by, is the early tooth loss and breakdown of the dentition due to a gum disease factor, or is it purely and simply a tooth decay factor that's related to the injury? And those are considerations that we have to make as well. So conclusions, I'm mindful of time, and I just want to have enough time for questions at the end, if there are any. Dental causation is multifactorial and complex. It requires an independent medical examination by a dentist. Pre-existing records and current clinical records are very helpful, but not absolutely critical in all cases. So there are many cases that I have seen where I am able to make a determination and have a fully completed report without pre-existing records. But obviously having preclinical records are helpful, and certainly having current clinical records are helpful in terms of what is the current state of the person's dentition and what is the proposed treatment. So that's definitely critical, but the pre-existing records I see quite routinely are left off, and I'm left to make a decision and contemplate and provide an opinion without pre-existing records. And quite often, with all the clues that I've just shown you, and with what we have in our armamentarium in terms of investigations and history and examination, we still can come to a definitive conclusion with the available material for causation and to determine whether the injury is compensable or not. However, pre-existing records are sort of best practice, and I would implore people who are case managers to make sure that they are providing pre-existing records where available. So really the ability to decipher causation rests with the rigor from the expert in obtaining all the available evidence using a systematic, repeatable process, which we do, to reach a set of diagnoses, form an opinion, and determine causation and compensability. Thank you for listening.
Thank you so much, Dr. Rohan. So we actually got a question. So we actually got a question from Lindsay, who's actually attending the live session right now. She asked, may I please ask how far back, like the number of years of dental records would you like prior to the injury medication for your examination, please?
Yeah, look, that's a great question. I think even if there are records that are pre-injury, any records that are pre-injury provide us something to compare against. So the closer the records are to the injury, the better, because sometimes we might have records that are 10, 15 years before the injury, and they've actually had another disease that has occurred, or a set of diseases that have occurred post that can't be captured. So it may not give us an accurate or a complete picture, as accurate or complete picture, but they're still good to view and still worthwhile having. But records that are as close before, so how do I word that? As close to the pre-injury time frame or the injury time frame as possible. So a pre-injury set of records as close to the injury as possible in terms of time is probably the most helpful to determine causation and to help in writing a report. So I hope that answers the question, Lindsay.
Lindsay, do you want to unmute yourself and maybe ask the question? Yep.
Wonderful. Perfect. Thank you for the presentation, Doctor. Much appreciated. Probably if I could just circle back to your presentation where you were talking about a dental question. What is your best dental question you have been asked, and what is your worst?
Are you talking about? Sorry, are you talking about the question being that asked
is posed to you? That's posed to you in the environment of a medico-legal assessment.
I see. That's a really good question. Can I come back to you on that?
Of course.
Yeah, the best, because I do have a set of questions that sometimes I look at and I just go, why are these questions being asked? So yeah, I understand where you're coming from. I'll have to get back to you. So I don't think I'll fairly be able to give you the best and worst off the top of my head. So if I can come back to you, that'd be great.
Not a problem. Thank you, Doctor.
Any other questions?
Yeah, I think that'll be all for today.
Thanks so much.
Thank you so much, everyone, for joining. Thank you, Dr. Krishnan.